Hello, viewers. Welcome here to another episode. This is the Para Podcast Show. I am Elias Thomas. I am joined by Malusi Mtetwa and Tulani Sibanda. And we have a guest out of the UK. We're joined by Amy Halck. I think of the green guy, Halck. She's going to be chatting to us about her experience coming from South Africa, going to work in the UK. And yeah, it's actually hot now when it's usually cold. Amy, welcome to the show and thank you for being here.
Oh, thank you guys very much for inviting me on this. I'm very excited.
You know,
Not as us.
actually, we appreciate the fact that there was no friction getting you onto the show, because usually some people you have to do back and forth for about a month before you get them on. For you, it's like
6 months.
Chat to you exactly. Can we chat? I think we have someone that we booked. I don't know. We've been talking to them for 3 months, and I think they'll probably come somewhere in August. Yeah, exactly.
As long as they come, yeah.
So thank you for being here. We really appreciate it. For someone that doesn't know who Amy Halck is, just tell us, who are you? How did you get into this crazy industry and this profession?
So my name's Amy Halck. I studied at DUT. I first did my NDIP and then I did my BTEC. I've always wanted to be a paramedic, I think since I was 10 years old. I just like the adrenaline rush of it. I like to help people, and that was a good mixture of the two. I wasn't into science, so I didn't want to be a doctor, to be honest. And I didn't have to have science to do my NDIP, so that was lucky. So I worked at Netcare when I first qualified operationally. Then I went to the college, and then about 6 or 7 years later, I immigrated to the UK. And now I'm a senior lecturer at a university in the West Midlands.
Since 10 years old, I don't even know if I ever thought of what I wanted to be when I was 10.
Now, I didn't know an ambulance when I was 10. I can tell you that. Possibly, maybe we've seen a fire truck, on TV, but not an ambulance. I don't think so.
Look, I don't know who I was chatting to, but kids today, all they want to be is podcasters, YouTubers, influencers. They don't even think about these careers that we wanted to be doctors, nurses, or even paramedics. But it's quite interesting that you, at that age, you wanted to be a paramedic. What is there anything that had an influence on you that said, okay, when I grow up, I want to be a paramedic?
My neighbour was Chris Boettcher, so I used to show me all the
Who's
pictures.
Chris Boettcher? Is he like a legend in South Africa? Or like...
He's a legend.
He's a legend.
Yeah, so he was the media liaison for Netcare for many years, and he used to show me all the pictures of all the accidents, and then I got to go to a family fun day the one day at Virginia where they had the old hens operation. And so that was just like cementing, this is what I wanted to do. So it was quite nostalgic when a couple of years later, when I was working, HIMSS came back and I got to work on HIMSS for a few years. And it was quite nice to work with the people that I'd always looked up to. So that was really nice.
I wanted to say, Chris Boettcher actually took this picture.
I know what picture you're going to show.
Yeah.
Yes.
Yeah.
Was that the one we did at Durban International, the old one, the old airport?
That was at Amanzimtoti. Amanzimtoti, close to the Civic Hall.
Yes.
Yeah.
You guys,
Malusi will be showing that picture for the next. I think that picture is probably more than 10 years old, isn't it?
Definitely. 2013.
It's old enough, Malusi still looks the same, on that picture as he does now.
Got more hair now.
Refusing to age. Right. Amy, I know, when you get into, the idea of a profession, right? When you see it on TV or when you see it, from a distance, it looks cool. Everything looks fun. When you got into the education, is it all that you expected?
No, not at all. So from obviously when you're learning to be a paramedic, that's just chaos. Well, it was 3 years for us back then. So that was a lot to deal with. And you're obviously learning stuff you didn't think you'd need to know. And then you don't remember half of it because you pass a test and then you don't really think about it when you're treating a patient. So when you move from practicing to actually teaching in the academic field, it's quite difficult to know that you have to teach things that people may not necessarily will remember in a week or two or when they're treating patients, but it's imperative that they need to know it for later down. There might be one patient where it might be linked and hope that they can remember it by then. But it is completely different to what I thought it would be when I moved into academia.
I like that. Elias, I like it because what came to me is that you learn actually when you are working. That's where that's why it's called practice actually, because you learn, you see a lot of patients and then you try to draw from the knowledge that you got from school. And then if you don't draw from anything, then it means that you need to go back and relearn. Yeah. And relearn whatever that you missed. Yeah. I like that, Amy, what you just said.
Yeah. I was just gonna say that so you've worked in South Africa for a while, got into education as well, and then you decided, no, I'm gonna try something else in the UK. At what point, what made you think, let me move to the UK?
So it was more of a family decision. So my husband found work here in the UK and I followed. And the problem was that COVID hit straight after he got here. So we were separated for about 14 to 16 months before I could get over there because of all the restrictions from South Africa and the UK and visas and moving a cat. It was all just logistically a lot to deal with. So, I mean, I was never against practicing in a different country. I do really miss home, and I still see it as home, and people still say, but your home is the UK. No, home will always be South Africa.
There's no biltong over there.
I mean, there is, but it's not the same.
It's not the same.
I found some places.
It's not the same.
They're not the same. No.
Yeah.
They have beef jerky here. It's called beef jerky here. It's horrible.
No, that's not cool. So that was the reason I did the move. I knew I could find work and I wouldn't mind if it was operational or in education. So I was just up for the challenge of something new and I took it.
Okay, that's great. And when you got into academia, of course you did not work in the UK. How was that for you? Because it's quite a different system as well. Because in South Africa it's very much critical care based, right? And then the UK is very much, supporting the community. The needs are very different. The scope of practice is very different. How did you get into the education? Like, what subjects were you teaching, and sort of like where did you fit in?
So I was fortunate that once I knew I had a visa to work and live in the UK, I then applied for work at universities, and I managed to get this on my first interview, so that was quite nice. So I went straight into academia, which was quite stressful because, like you say, in South Africa, we are training people we focus on emergency situations. There's very limited, I know when I was training, very limited teaching on like palliative care, community work, antibiotics, things like that. We're focusing more on your traumas and your critical medical emergencies and your IHTs. So it's quite different here in the UK where the focus is, there is a bit of trauma focus and you need to because it happens, but the volume at which it happens is a lot less. And the link to resources like advanced care, whether that be HEMS, a critical care doctor, or like an advanced trauma center, is really close most of the time. So they don't have to have the level of training that we had because they're not with patients a lot of the time for as long as we are. I know in the trust I train people to work for, the areas that they are in placement, there's only one real area that's with a patient for about 40 minutes. The rest of them have got like a 5 to 10 minute transport. There's like 1 or 2 areas. So, but most of the trust is just really quick, short transfers, short patient interactions. And they've often got, not always, but they've often got some access to advanced care at some point along the patient journey, which they're very, very fortunate for, which I'm not used to seeing that coming from our context.
Yeah.
Don't you miss working in KZN operations?
I really do. I really, really miss patients. I really do. I would love to work operationally here. It's just a lot. The scope is very different, and it's just difficult to work like bank, so overtime shifts with the trust. I just don't have the capacity to work 6 days in a row, and I'd have to work that if I wanted to work for the trust that I'm in. And I just, I miss it. I miss the diversity of the patients. I miss the diversity of the calls, the distances that we traveled, the thinking that had to be involved, whether that was on the road or HEMS. I just really do. I really missed it a lot.
I think you mentioned some big words there, working bank. For someone that has never worked in the UK, this might sound very foreign.
I thought it's working in the bank.
What does working in the bank mean, or working bank mean?
So bank shifts are like overtime shifts, so that you go onto a roster. So if you don't want to, you're not a full member of staff, you would then just fill in the gaps. So if they had short staff for shifts, then they can then call on their bank staff to kind of boost them up to their normal levels. So different trusts in the UK work on different systems. Some of them work that you need to work so many shifts in a period of time. So for existence, 1 shift every 4 to 6 weeks. And other trusts, like the trust that I'm closest to, they require 1 shift per week. And with a full-time job and working 1 shift a week, I just don't have capacity for that.
Yeah, it's hard.
Yeah.
You are registered in the UK, right?
Yes. So I had to be registered for education. I don't have to keep my registration, but I do. So I am registered both in South Africa and in the UK. So I have to keep my CPD up on both.
I
hope you didn't get an email during this submission. Good.
I got the email.
Stress.
No, but I never worry about it. No, I'm registered at the university, so it saves me a lot. I just sent, so it's not too hard. It's not too hard.
Okay. Yeah. I know you did mention that the scope of practice is very different. And, I have worked in the UK, and you'll be shocked at, sort of like the autonomy that is given to paramedics. But you also get to appreciate that the system is very different. You mentioned that they will be 5 minutes. The longest might be 40 minutes, while for us, it might be for an hour in the South. So how is the scope of practice different? And, from a teaching perspective, what differences did you see?
So paramedics are trained at not a critical care level to start off with. So it's a 3-year degree. And not to offend anyone, but the only way I can try and figure out how to, from a South African context, is that it's like an ANT paramedic with less stuff. That's it. So our ANT paramedics have got a greater scope of practice than the degree paramedics that come out of the UK system. Just purely from the fact that they don't have to have the extra skills like we have to have back home. And so what they make up on those skills, or lack on those skills, they make up on more community-based skills. So a lot of the courses do have like minor injuries and minor illness built into their curriculum, so that if they want to work in a minor injuries unit, which is, so as the name says, it's not like an A&E department. It's where you go for like minor injuries. They can do that. They can work in GP surgeries as well with that qualification or module, part of their certificate. We also do more things like palliative care, which I know that South Africa is doing a bit more on trying to get more awareness on that. And I know it's quite a struggle trying to get that implemented. But there's a lot of palliative care here in the UK, where we even have specialist palliative care paramedics. So there's lots of avenues for the UK paramedics once they graduate. They don't have to go on a yellow box. They can they've got diversification. So they can work in prisons, custody. They can work in A&E departments. They go in HEMS if they want to do further qualifications and do critical care. They go at palliative. They can work minor injuries. List is quite extensive,
It's
not just like us where we get qualified, get given the keys to a car or an ambulance, and that's where you're going.
Yeah, no, I was going to say that, with all these avenues, the paramedic scope in the UK, I feel like they have exhausted the other bit and they are specializing now more. In terms of the postgraduate trainings that, after you do your base degree, what other trainings does your university offer to make sure that graduates can enter into other fields? I know that minor illness has been there for a while. And I know there is another one that allows them to work into CHUB, like for instance, where you get the calls and triage calls and so forth. What other qualifications are there that your university is offering to these guys once they finish the bachelor's?
So there's every university is different. So some offer postgraduate courses, some offer just modules on their own. Other things can be ACP, Advanced Critical Practitioner, CP, Advanced Clinical Practitioner, I think it is. They can work anywhere in a hospital setting. They don't have to be in an A&E department. You get them in theatres, you get them in ICUs, in wards, and they work alongside the doctors. So they have an advanced scope of practice. Nurses can also become ACPs as well. And that it's like a master's. It's a master's qualification that paramedics can get over and above their normal degree. Prescribing can be a standalone module, or it can be included in this ACP course. And some trusts are allowing paramedics to do the prescribing so that they can go and work in the communities and try and be like a community, just work as a specialist paramedic, I think some of them call them. And that way they're trying to take the burden off the ambulances, because if a patient just requires antibiotics because they've got a UTI or they've got an infected diabetic, or they can work together with the diabetic nurse to get the sore dressed but they can also prescribe the antibiotics to take pressure off the GP surgery and the ambulances themselves. So if people want to do critical care paramedics, which is required, a lot of trusts have cars, are normally staffed by critical care paras. They have to have a qualification or work towards a qualification, or if you want to work on HEMS, and that is a master's program that is run by a few universities where they get a master's in critical care in essence. But there's not many universities that run those courses.
I was just going to say it's so difficult to get onto HEMS, even though you can do the course. It's absolutely difficult, like the queue. I also know that you mentioned prescribing as well. I actually just got an email today that New Zealand will be starting their prescribing, acknowledging paramedics to prescribe, which I think is, obviously in the UK it's been there for ages, but they have not been doing that. I'm not sure, Australia, anything happening there, Malusi?
Now, we don't prescribe much here, but I think the system is a bit different. You would have SCP, extended care paramedics, that would carry antibiotics. They would also do the wound care, the wound care, and they'll be fixing up catheters and all those things. So they'll be preventing patients to going to ED. They work a lot with nursing homes and things like that.
That's good.
Adding to that, there will be community paramedicine, which is still fairly new in Australia. And I think there is a university that has started offering the course on community paramedicine. And as it is emerging, you want to have people that can prescribe antibiotics, do bloods and all those things, So there is a bit of a diversification that is starting. But I do feel that the ECP part is still very, it's like getting into the hem course. It's difficult to get in that. Like I don't remember a post coming out saying that they want ECPs ever since I was here, and not that I want to go to the direction too.
I
was just mentioning that. Yeah.
Okay. Amy, the education system is different. Training a paramedic in South Africa and training a paramedic in the UK is very different. Chat us through the subjects. What kind of training would you normally do, and how is it different from South Africa?
Well, first of all, which is still 4 and a bit years later, I'm still trying to get my head around this. So the HCPC, which is the governing body that regulates paramedicine along with other professions, does not write a curriculum and say you need to do this. So every university, they get accredited by the HCPC, but they don't follow like a set template. So it's quite difficult because if someone comes to the university I work at, they won't have the same modules as someone who goes to another university. They might be similar, but there's not the same. There is the College of Paramedics that is trying to make a curriculum that people can follow, but not everyone's going to follow that because it's not like a requirement by the HCPC. So that's the first thing that's quite different. So the kind of modules that we have is in our first year, it's very communication focused, and getting those basics done in your normal skills. And we have modules on vulnerable patients. So talking about inclusive care. So looking at the diversity of our population and how can we treat them, what kind of, issues might we find that might be in those systems? So what kind of vulnerabilities might be present in certain areas or certain demographics? And we've got placement as well. So that's where they get a couple weeks every semester where they go work with actual patients. I think that's it. In second year, we do try and build on that. Where we try and take what they've learned in first year and build on it and go more in depth in the patho and the physiology and the pharmacology. It's not as pharmacology heavy as it was in South Africa. We have an actual pharm module and a patho module and a physiology module. It's all just culminated together to try and link the condition with the signs and symptoms, and linking it to what we can do within paramedicine and within the scope of practice that is regulated by JRCALC, which is the guideline, people who make the guidelines for all paramedics in South Africa. And then in third year, it's kind of polishing off those skills, adding in those extra ones that are going to help with the community, such as your minor injuries, minor illness. We do research in that year as well, and we talk about patient safety and leadership so that by the time they're qualified, they can then take over that. We can work towards being a leader, not only while working on an ambulance, but hopefully with when they get students and as their career progresses. So that's kind of how our university kind of structures. It's a spiral curriculum, so we try to build on 1 year on top of each other.
Which is very different from the way. And I was just gonna ask, obviously it's a very different system. When you see the students coming in on the first year, and by the time that they come out at third year, because I know one thing about the UK is that they do try and push for you to be on the ambulance as much as possible, so that you can gain that experience on their own. How do you see the transition and the growth, even though the scopes might be different? How do you think the students, the confidence and the practicals and all that? How's that? How do you view that, or how do they look like? If you can just paint a picture for us.
It is quite different comparing to South Africa. I guess the they don't have as much time that they have available to work in practice, so it's quite condensed, and they've got a very limited number of shifts that they have to get their competencies signed off. We do also have every year has got a week of alternative placement where they work in a non-ambulance environment to try and build that interprofessional connection. Or it could be a simple thing as just learning communication. So if they go to a school in first year, they're learning how to communicate with children and potentially those with special needs. So I think it is quite the growth in going from year to year, because they're so limited in the number of practical hours. They still are very stressed and not. They have confidence in the areas that they've done. But I do see some students who haven't been lucky enough to be into a cardiac arrest or treated an MI patient. And they do have that fear when they come to the end of their third year, when they realize, I'm going to have to lead this patient and I haven't had exposure to it. So I do worry, but there's just not enough hours because there's so many students that there isn't enough time and enough time able to be allocated to every student to get them more shifts. Like in South Africa, we had weeks and weeks of RV, ambulance, like ED departments, theatres. I think we had a lot of it was just with patients. I still didn't feel confident. I still did extra shifts just in case. But I do worry about the number of hours that they do have. And I mean, they have enough to pass and to be competent. It's just how many of them will use that limited time and really put all the effort into it, or wait until the last minute and be like, oh, let's sign things off.
When you said RV, I thought of RV32. Was it RV32, right?
It was RV32 and then RV33.
Yeah. Good fun. There was a goal
Central.
Yeah.
32 was
Central. Yeah.
33 was us, and then 34, we became 34 at one stage, but it was 33.
Yeah. It was a Golf 7, Elias, if you care to.
Oh, yeah, that's what I'm trying to sort of like pick up. Like, what are we talking about right now?
Yeah. It was a Golf 7 response car. So the RV is a response vehicle. But what I wanted to say, what I'm learning from this is the UK has mastered the system of utilizing the skills of paramedics. And it's not only focused in emergency medical care. It looks like you can have other career options that can work for you, even if you do not want to be in a fast car. You can be in the emergency department. You can be in ED. You can be in the community too. It's something that is embedded and integrated in the system of education, even before you even go there. I do think that, and also what I also noticed that on the first year, you mentioned education around vulnerable communities. I think you do have that also in Australia here, where they learn about working with the indigenous community. And I think I remember in South Africa, we were learning a lot. I think there was a subject or a module or an assignment that has to do with HIV/AIDS. I remember those things. Yes.
I remember it was one module. It was like 1 week. And I was done.
Yeah, it was complicated. Not that I enjoyed it. But so I can see that there's that adaptation to the environment. But I do think that personally, I feel that like in South Africa, we should try and spread it wide and have more options to utilize people that are working in the ambulance service. I do think so. I think there could be great benefits. I think there's a great room for community paramedicine. I think there's a great room to allow people that work, that do not want to work in the ambulance, to work in the hospital setting and other avenues, and to make it something that is out there, that there's an option. It mustn't be for the selected few who are lucky to get there, you know? It must be something that is well known that there's that option. Yeah. I think, yeah.
So I think the UK, I mean, there's still some teething in this, depending on the trust that you work in. like the province, or determine how many of these services are actually available. But as a whole, there are more than one avenue. There's more than one avenue available for paramedic students to graduate into. And I really do believe that South Africa could use community paramedics a lot more, especially if you like the vast areas that needed to be covered. You could have them working in clinics, so they've got access. Patients can have access to more advanced skills, because I know nurses are quite limited to what they can do, and they try the best that they can, and they aren't always doctors posted at these clinics, or they're only at certain times of the day. Whereas if you had community paramedics who could be helping with wound care and suturing and antibiotics and just those things that, like I said, preventative care, to prevent them having to go to A&E or worse. So I think it's definitely something that hopefully one day we could see in South Africa.
So
Yeah.
You wanted to say something, because Marisa, I wanted to ask a different question before.
I wanted to say, I know that Mr. Madinga, who's in the UAE, is studying his PhD is around community paramedicine. So we do hope that there will be some implementation sometime in the near future around that space.
Good.
So look, Amy, why are you laughing now?
I'm laughing. Oh yeah. I agree with that.
No, because
yes, you can continue.
Because I didn't want to lose my train of thought. So look, Amy, the discussion that you guys are discussing now, I can sort of reflect, although coming from the university in South Africa, is that we were never trained to work in a hospital setting. I worked at emergency department at Medcare, Mopak mostly, and also at Garden City. I was able to function as part of the team. But also there was a cancer hospital in Durban that
Parklands?
I forgot, it was a private. It was not one of the biggest cancer hospitals in Durban, but they hired local paramedics to work there in case a cancer patient deteriorates or goes into cardiac arrest, so that we'll be able to lead the team. And it's actually the first time that I talk about it. Now that I think about it, I've never even put it on my CV.
I mean, you've spoken about palliative care. Dr.
But you
Omoya,
never.
And you never confessed that you were trying to keep people living that wanted to die.
But I've never put it in my CV. That's the thing. But I think now that I think about it, is that we have the training that we do in SA, although it doesn't say you train to do X, Y, and Z, or to, I think it does, I don't know how to say it. Although the training that we do in SA doesn't train us they don't specifically say that you are trained to do the X, Y, and Z, or to function in that. But once you're in those spaces, you're able to function as a team or to find your role based on your training. What I wanted to backtrack on is that when you spoke about the different training institutions in the UK, you said that different institutions in the UK offer different paramedic curriculum training. And when you compare that to South Africa, or even Malusi and Elias, where you guys have worked from, based on your experiences, is that how does these variations in the paramedic training from one college to another or university affect the students' learning, or affect the team collaboration, patient care, or even how they function as a team in the hospital? Because in SA, the training that we have, basically, it's more or less the same.
All the same.
Yes. And for me, coming from that environment, I can tell you that it's easy, because when you get another ECP or another university graduate, you're at the same level in terms of, and you're able to function as a team in multiple scenarios. Whereas I can think in the UK, if the training is from one institution is different, it might pose challenges. I don't know. What do you think, Amy?
Definitely agree. And that's something I still try to get my head around, is so the trust that I work in.
Do you trust it?
Yes, because I live here as well, so I need to trust it. And I'm training people for this trust, so I need to trust it.
So much trust in that. Okay, good.
There is a lot of trust in this. So JR Calc, which is they create the guidelines, and they take, it's actually a really nice system, and I don't know if something has developed in South Africa similarly to this, but it's an app, and it's got all the medications, all the guidelines, all the algorithms, it's all there, all the maths is done for them. You just click on a button, you don't have to really think, which in a way is good, but also in a way I'm a bit like, you should be able to think in a stressful situation. So that's national guidance, but not all trusts will pay for the medications that are on there based on their own reasons. So, for example, magnesium sulfate has only just been brought back into the paramedic scope of practice for eclampsia and severe asthma in the last 2 years, but not all trusts have got access to it. I don't know if any trusts actually have got access to it.
London doesn't have it. London doesn't.
No.
Yeah,
So
I think SCARS
West
does,
Midlands,
but London doesn't.
it's strange. And so basically each trust then looks at the guidelines as they are, and they say, do they think they need it? Can they warrant it? So some trusts have got amiodarone, that is pre-filled syringes. Others have got the ampules. So now JR Calc has updated the app to include both of those, so that depending on where you are, you'll hopefully know how to draw up amiodarone during cardiac arrest. So Yorkshire Ambulance Service, I think they train their paramedics. Their paramedics can cardiovert, they can't pace. So the universities in that area, in that trust, will train their paramedics to cardiovert, because they're assuming that if you do your training in Yorkshire, then you're going to be working in Yorkshire. So you'd need to know that. But if a student, for example, trains at the university I work at, I tell them this is cardioversion, this is pacing, this is who would need it and why, but they don't actually get to practice it and become competent in it. So if they then go work in that trust that does do it, they have to be upskilled to do that in order to obviously meet the requirements for their job. So it is quite a tricky situation, that there's so many differences between the trusts, and that you would think that's one, like you said, like if I know that if I had to work with any of you, we all have the same qualification as a bare minimum. So I'd know what you could do and what we could do together, and who we need to help, like who can help us. But a paramedic in the UK, unfortunately, if you're working with someone who's trained at a different university or trust, you could have differences in scope of practice and medications and things like that.
Yeah. To answer your question there, Tulani, I'd say there are differences too here, depending on which university you started in. They train you for the states that you're going to be working in. So it's sort of always associated with that, as much as they can add more knowledge to it. But the end goal is understanding the scope of practice of where you are likely to do the interview, where you're going to get internship. You know, in my cognitively, that's what you've been thinking about. In terms of integration between other states, if you move from one state to another, you'll have to attend an induction. It's going to be like 6 weeks, where they teach you. Obviously, the laws are not exactly the same too. The laws of the road, the rules of the road are not exactly the same. The driving rules in the ambulance is not exactly the same. You'd have to convert your driver's license to work here from another state. And at some point you can work, but at some point you might have to, obviously your address changes, so you'd have to change your driver's license. Or your driver's license actually appears on the address appears on your driver's license.
I'm thinking you're moving from Western Cape to KZN. You have to change your driver's license.
Yeah. So, and then also, the other thing that I normally find I see hard from people that are moving from other states coming in, because you do have to be shadowed by someone else. There is a struggle with the organizational culture, the culture of the organization, how they do things. There's a lot of structure in terms of how do you do things. We know exactly that when I arrive at work, I'm going to grab the keys, I grab the pager, I track the drugs in that order, or whatever. That part has to be done in the morning, exactly like that before you actually start. Then you log on in the system, But then when you arrive, you don't know that. And that has nothing to do with you being a degree holder, It's organizational culture. You have to learn that. So they'll struggle with those things. And also in terms of the skills, there'll be differences too, in terms of the skills that are done in different states, and they'll have to learn those skills or cut from other skills. I think our state has actually less skills than most states, for paramedics. It's like there is no paramedic in this state, I think I've said it before, that can actually RSI on the road in the ambulance. No one does that on the road here. It's only MedStar. Even in ED, doctors don't RSI. They have to get an anesthetist to come and RSI and do all those things. It's a skill that is activated by the doctor will call in the anesthetist, and then after that they'll start that process. So it's very different from state to state. And I'm sure that if you go to other states, you'll find that it's different. In Melbourne, the state of Victoria, I think they have the stroke unit, which is also totally different. Yeah. And they have started the master's degree that has certain specialties that they add for their clinicians. So it's different from wherever that you're studying. To another point that Amy mentioned about remembering your drug doses, I think there's something that I learned here, that you try to reduce cognitive load. Yeah, cognitive load a lot. Yeah, and it helps sometimes. And sometimes you think, what was the dose for that? And then you pull out an app. We do have the app here, and then you check the dosages and stuff like that. And sometimes if you're under pressure, it's hard to read fast. So you read, especially, even worse when English is your second language, but no one knows that yet. So you have to read to a person and ensure that they understand what is happening. And then you agree what is happening, what drugs are you and how you're mixing it and stuff like that. Yeah. So it helps. It helps a bit. But I do also appreciate that what we were trained in, you have to remember the numbers and be on top of it. Yeah.
No, I get that. I appreciate that this technology's changed and things are developing. But I do think there's a nuance to actually knowing how much you're giving and not just you should just know it. In certain situations, I think drugs that exactly, and then you know that for certain drugs you shouldn't have to be checking because it should just be ingrained into you. And then the things you don't use as often, like check away. The things you should know certain things.
Yeah. I definitely agree with that. I was just going to say to Malusi's point on, I remember some of my colleagues were sharing with me in New Zealand that there was a point where the regular paramedics would not do a 12-lead ECG. They had to call for a CCP to come do a 12-lead ECG. And this was about maybe 10 years ago or so. But, you think of it and you're like, like every other paramedic should be able to do a 12 ECG, but it was reserved. But it's the hierarchy of skills, just like the RSI. It's only an anesthetist that can RSI and so forth. And just in terms of to answer Tulani's question as well with regards to changes, I guess for New Zealand, which I can comment for now since I spent some time there, there's only 2 training colleges. Again, just like what Malusi has said. Before you go to that specific employer, you kind of have to learn their culture, their way of doing things. Whether it's, I don't know, St. John's pretty much rules New Zealand. So it's their way of doing things that you probably have to follow. I remember during my time in the UK when I got there, we had to do an induction. That was about, I think, 4 weeks or so. And then you had to still be on placement for 6 months, or you have to work with a paramedic under the wing of a paramedic until you actually understand the way of doing things in the country, and you actually adapt it. And because you still have that little bit of warrior in you that but you should do this, but you can do this because you've done it and you've independently done it. Like, you have to understand, oh, I can't just cut your veg, it's not in my scope of practice, but you see it and you want to do it, and you're like, why am I only carrying paracetamol when I can carry other stronger things? But those are the changes, and you kind of have to adapt to the culture and the way of doing things and follow their training. Just to move on from this point, I just wanted to move to education. I know that around the early 90s, when the internet came into effect, like, it changed the world completely. Everyone had a website, and it was looking amazing. Now the next big thing is AI, and it's everywhere, and you can't hide from it, and it's taking over everything. I remember someone telling me that they used to do a project for, like, an advert for, like, 40,000. They had to have a budget of like 40,000, I don't know, whatever currency, US dollars. But now you can do it for, less than that, even like a quarter of that, because a lot of the load is sort of like, I don't know, you don't have to do much. With less resources, you can do so much. I know that at the college that I'm working now, they have implemented AI into the education. They are looking at, teaching LLMs and teaching different kinds of things of AI. Is this something that your university is looking into? And what part of it is it?
So the university has got an AI policy. So we're looking at, because you can't think it's not being used. So there's rules around the use of AI when it comes to submissions, and there's a policy document on that students are given to talk about and show them, if you're going to use AI, there's obviously certain parameters you can use it in, and you're going to have to reference it as well. You can't just say, oh, I thought of all of this by myself. But we do have, I think they're trying to get some software in that can pick up in submissions on Turnitin, that can pick up how much of it is AI generated. You can see an AI generated essay. It's got a format to it, and suddenly you see these references and you're like, oh, that's not even it. Wow, what is that? So there are some people that are still trying to submit AI as if it wasn't AI, and then they fail. That's assessment. But we have to understand that it's not going away, and we have to work with it, not against it. Our course doesn't have many things that would require, so we have some essays and presentations, but we mainly a practical assessment course. So we try and do things more practically. You could use AI to help maybe create your presentation, but you're going to have to deliver it yourself. And then like OSCEs and SIMs, you're going to have to do yourself anyway. So we're quite lucky in the fact that AI, there's only a small portion of our assessments that could be affected by AI, and we're trying to work with it, not against it, when it comes to students using it.
And is there any plan to, I don't know, teach the students, because this is going to be the future, on how they can use it effectively and to understand it? Is that something that your program is looking into, or as a university as a whole?
I'm not sure as the university as a whole. I do think there are some courses in the university that do teach the use of AI and how to use it to better themselves in whatever their profession is. We're actually going through a course revalidation. So I wouldn't be surprised if we had to include something with the use of how can you use AI to be the better paramedic. I know GPs are using AI technology to help with their transcription, with their note taking, and they will say to you, I'm using an AI generator to transcribe this consultation. So it is definitely in the medical field. It's how do we see it being taught in paramedicine, and how beneficial would it be for the future, I guess.
Yeah, it will be an exciting thing to see how the future unfolds, especially with all those things that are coming along. I think perhaps just looking at your time that you spent in the UK, there are some good things that you have seen from the system, and that you could possibly say to Tulani, who's running a college somewhere, let's say, for instance, Netcare or Lebone, or someone that's doing training at Namibia University of Science and Technology, to say that actually this works. And perhaps you can consider it. What are some of the things that you kind of, appreciated being part of the UK system that you think would work great?
And this is probably going to be controversial to some people, but
Yeah.
I, as much as I enjoyed my rescue,
We didn't ask you. You just said it yourself. Yes, continue.
I can say that I was the fittest I was ever in my life. Was in the 3 years DUT, because the fear of failing pushed me through physicals. I really, the knowledge I learned was really interesting. Did I use much of it as a paramedic in an urban to slightly rural area? Not much. I think the only bit of my rescue that I really used was extrication and maybe a smidge of rope rescue. So I think if that could potentially in the future have a separation between a rescue and medic and training with rescue versus just training without it, and having rescue maybe as like an optional thing. I think that would be really good, because just seeing how much more time people have here to focus on the paramedic side of things rather than having the stress of having the physical aspect. And I'm not saying that physical is not good. And I know there's a lot of research out there, as is could be expected. The fitter you are, the better paramedic you are going to be for your patients. And I 100% agree with that. But the rescue component is a lot to add on to a really big degree, where you could focus more on the patient from a medical point of view rather than a rescue point of view. So I think.
Yeah.
Lucy, I feel like you told me the end.
Like me.
I have nothing to add. She said everything that I agree with. And not Tulani has other thoughts, but I like what you've said. I fully agree. Rescue was fun, though, I must say.
Look,
it was. I loved it. It.
I just want to say that someone today on our private WhatsApp group, on the group WhatsApp, he said that he's playing soccer. I'm not mentioning any names. And obviously the heat plays a role, but he realized that he was unfit.
It's winter here, I must say.
I'm going to leave it out there. And all I want to say is that Amy said that we need to be fit as paramedics. I'm just going to leave it out there. But anyway, look, there is a rescue course that the University of Johannesburg is running. Not that I'm selling it, but I'm just saying that
You can sell it. It's okay.
No, I just want to mention that there is an advanced rescue program that the University of Johannesburg is running. And I think if people want to diversify their rescue, they want to focus more on rescue instead of the medical, they can go and do that course. I think it's one of the first in the country that is doing actually that. However, when you look at the rescue part in the essay, look, I might be limited in the information that I'm presenting, that if you look at the municipalities that were doing rescue, not a lot of them are doing actual rescue, but also it's limited to, a lot of it depends on the province that you're in. Like if you look at the city of Joburg, there might be some of the drums that they do, especially in high rain seasons, but a lot of it has to do with fires and motor vehicle rescue. But that's something that people can do if they want to do rescue. Consider doing an advanced rescue course module from the University of Johannesburg.
Yeah. Thank you for sharing that. Hopefully, if anyone wants to apply, just know that it's physical, okay? Amy, I think I kind of want you to make two comments on two things. One is just the postgraduate, just because we're running out of time, postgraduate training for the paramedics in terms of the mentorship that happens in the UK. What your thoughts are, and how do you think it shapes the clinicians that you see in I almost said South Africa, but in the UK, there's, I'm not sure if you had any mentorship when you finished, and how do you think that could have impacted you as a clinician?
So I'll start with the first part, or second part. I had no mentorship. I would say I had mentors throughout my 3 years at DUT, doing my NDIP, but they were more just me attaching to people and kind of just being like, please help me. And those three were really instrumental in helping me to be the best paramedic I could be. And then I have still got some friends now that, in essence, I guess I was the mentor for them, and I didn't know I was a mentor. I just kind of assumed the role of, you're a paramedic, you'll get a student, and you're going to help them. Whereas I don't know if that's changed in South Africa. I don't have any, like you say, I don't know how up to date it is, but seeing how mentorship is done here, every trust is different once again. Every university has got different mentorship, or they call them practice educator training. However, just seeing that there is something that's given to people to help them to know what they're doing. Because I don't know about you guys, but I didn't know what I needed to do when I was given a student. I was just kind of like, okay, what would you like to know? And then they would ask me a question. I'd be like, did I learn that? And then I'd have to try and figure out where in my brain I stashed that information, and hopefully not look too shocked when they ask me about like something that maybe I should have known straight away. So I'll take from our university and the trust that I work within. So we run a 3-month, 5-day, what we call 5-day practice educator. And they normally have to have the 1-day practice educator prior to that. 1 days are just there to help with everyday mentoring. 5 days are who have to sign off their competencies summatively, each competency in their document, along with their placement as a whole. So they have to sign off the student's placement. We've got no hold on that. So 5-day mentors, they normally do a 3-month course where they've got training there's 5 or so, it's 5 training days, and then they have an essay to submit or a presentation at the end. And part of that is they have to show evidence of training. So they would have shown evidence that they did sit with a student and they went through a plan, and what did they do? What were the actions from that? What did the student perceive? Was it a good session? Where could they improve from? So it's about closing that loop. So I know that's within our trust. Other trusts, they don't have to have the 1, then the 5. They go straight to being just a mentor or a clinical mentor, as some people call it. But this training that's given to them, most of the time it's people who want to be mentors. But because the shortage of paramedics that would have more than 2 years experience, a lot of them, when they hit the 2-year mark, they're kind of told, we're putting you on this course, you're doing it. So I do think it's ahead of what I know as mentorship in South Africa from my personal experience. Is it perfect? I don't think so, but I think we're heading in the right direction. I'm just not sure if South Africa has gone down the more formal mentorship route in their paramedicine.
Yeah, no, and I like that. I like that one, for that the people that are training the people. I think knowing something is one thing, and being able to teach and guide the students through it is a different thing. So I really like that there is some form of training that the instructors can take in order for them to instruct the students. I think this is probably going to be my last question on this, just because we're hitting at the hour mark. You got onto the education's ladder, and now you are, I would like to say, a South African girl, that's working in the UK now, that's teaching in the UK. I'm not sure if that's big for you, but for me, if I was in your position, it would be big, right? So, yeah. Sort of like, just what trainings did you have to do in order to get to, like, from all the positions that you had to I don't know, that you have occupied before you got into senior lecturer position, and what else is ahead of you? If anyone was to follow through your footsteps.
So, although I had been in education for 6 years by the time I moved to the UK, because it wasn't in the UK context, I started as just a normal paramedic, as normal lecturer. But I progressed quite quickly because I showed early on, I said, I want to get more responsibility. I want to help lead the team. So I took on more responsibility, and within 2 years, 3 years of me, 2 years, I was a course lead for what we call a top-up course. So those who've done the foundation year, so there used to be a 2-year foundation year, and then they had to, almost like we went from NDIP to BTEC, they had a couple modules to do on a top-up level to get to paramedic status, or HCPC registered full paramedic, not just a top, like an NDIP to a BTEC, I guess, but not, pretty much. Then last year, I was given course lead for our current course because I was a senior lecturer now. I did progress a lot quicker in the couple years I've been here in the UK, and I've put a lot of effort and time into it, and I've shown them that, well, I hope I have, shown them that I do, I want the responsibility, and I'm owning it. From an education point of view, I hadn't done my postgrad in tertiary education or higher education in South Africa. It was always something I wanted to do. I just didn't have the time to do it in. So within the contract at the university I work for is within the first 2 years of my contract, during my probation, I had to have started or completed a postgrad in tertiary education. And in the UK higher education setting, there's something called fellowship. So I had to become a fellow in higher education. And that's just a piece of paper. So I did that in the first year that I was here. And so I've got that qualification. So from an academic point of view, I've got a teaching qualification at level 7, which is like the start of the master's on higher education. So it's a postgraduate certificate in health, high professional education. That helped me get onto the master's program. And if all goes well, in December, I'll be submitting my dissertation. And so hopefully next year I'll be graduating with a master's in medical education.
What is it about? The dissertation?
So, my dissertation, it is a systematic review that I'm looking at. Pediatric weight-based dosages. So because in the UK, obviously you've got Halck, which I've mentioned before, tells everyone what to do for the pediatrics, and they go based on the age of the patient. And they say, if this patient's 5, give them this, 7, give them this. They've done all the maths for them. And if you have a look at all emergency things, drugs are important for weight-based, or weights are important for drugs. So I'm doing a systematic review looking at how accurate are these, and should we be doing more actual weighing of patients or using more than just an age to work out how much drug to give? I know it's been done quite a bit. I'm trying to focus it more on the paramedic side of things. So that's my research.
Once you're done, please come back and have a chat with us about it.
Okay.
Tell us, what did you find?
I
think Tulani had something to say.
Yeah, so look, the more you spoke, I just have 2 more questions, but the things that I wanted to say, the hospital that I worked in Durban was Capital Oncology Hospital. I don't know if you know it.
Oh, yeah, I actually know that one.
That was 2014. And then when you guys spoke about paramedic mentorship, I think mentorship plays a vital role in shaping the confidence, the competence of paramedics. And it goes beyond the clinical skills of mentors that help to guide the junior paramedics. And for me, 2010, I had a mentor, Alistair Lidco, and I think there was a role of having a mentor during that time, during my paramedic training, because of it helped me to grow as an individual, whereas working with different people. So how we did it was the University of Johannesburg is that in third year, they assign you a specific mentor that you get to work with, and that person, it helps you to be disciplined, and they teach you how to function as a paramedic. So for me, that helped a lot. Now,
Didn't know that.
just to throw a spanner there, Amy, just two more questions, just two. Elias, I know you're running out of time.
You had like two, brother.
No, there was two comments. Anyway, Amy, you mentioned on senior lecturer, in addition to doing postgraduate qualification, like your master's, is there also a link to any publication that you have to do in terms of increasing from junior lecturer to senior lecturer, and also other stuff that you need to do? I know from the University of Johannesburg is that you have to have some teaching and learning portfolio that you have to produce. There also some publication and X number of experience that you must have had within an institution. Is it similar to what happens in the UK?
Yeah, so it is similar. Our university, we have go through what's called a HERA process, which is basically where you say, okay, if you want to go from lecturer to senior, you have to prove that you are working at that level already and you are contributing to the wider university and not just your team. So things like course leadership, I'm connected to the university, not just my team. I did co-write a paper that was published, so that helped a lot. I was helping. What else do I have on my HERA application? I showed I was doing course development, so I helped with writing some courses, I helped with writing assessments, validation of these things. So I had to show the wider, I was leading, I wasn't just lecturing, if that makes sense. So that was kind of the aim around the HERA process from my university. But all universities are different in what they require from going from one to the other.
Okay.
Does that answer your question?
Yeah, it does. And one more, this is the last one, I promise, is that are you allowed to share a bit of your results in terms of your study, in terms of what you found in the systematic review? Because if you think about it, wherever we practice, I know in SA we had the Popper tape. I forgot the guy that did it.
Prosler. The Prosler?
Popper and the Prosler.
I used
Popper was better.
The Popper tape, where you take, you measure the patient's length, and then they did a modified one, which I never got to use.
The Excel one.
Yes. And it also came with a flipper chart where you can get a reference. And then I know there was a pulse one where what's the pulse one? I forgot, but the pulse one had a chart that you look at, you get the patient's weight. Whereas when I moved and worked abroad, it's mostly the apps that comes. In terms of the pediatric estimation weight, what do you mind sharing a bit on what you found?
So far, obviously the scale is the best. And then it goes parent or guardian. So those who are actively involved can know like how much their kid weighs. So if we had to go to them in emergency, how much they could say exactly how many kilograms they weigh. The age-based stuff is actually quite far down because there isn't just one age formula. There's like 5 or 6 formulas. And every country, sometimes within a country, has got different age-based formulas. And then the Popper tape has come up high, and Brosler is also quite low as well. So that's so far what I found. It's just trying to write it all up.
Okay, interesting. So please, as Malusi highlighted, when you're done, it would be interesting to talk about it because it has a significant influence on how we practice.
The only problem with the Popper is that it's very South African. I think it's branched to us, I think, based on some of the articles. But because it's only been done in South Africa, it's really good papers that Professor Wales has done. But the rest of the world doesn't know. They don't really have access to it to be able to see how well to use it in such a diverse population. Because in South Africa, I like to say we've got very undernourished to very overnourished kids.
Absolutely.
And having a 7 as an age, there's 7s that are skeletons and 7s that are a little bit more well.
Yeah.
And you got and the ideal body weight, you can't look at it and go, you're this much and the 7, I'm going to guess ideal is X, because guesstimation can cause either under or overdosing.
Amy, thank you very much for joining us. We appreciate this, and very insightful. A lot that I personally learned from this, and your journey and everything else that you're doing. And I think just the conversation overall. So we appreciate you coming. You are gonna be featuring in our August month, month of women. We're gonna be
Women's Month,
Women's Month. Yeah, that's the proper way of saying it.
Yeah.
But thank you very much for coming on to the show. We really appreciate it, and that's it from us.
Thank you very much.